Hi and welcome to ACI 2020. My name's Mamta Buch. I'm an interventional cardiologist from Manchester, and I'm delighted to be joined by Bushra Rana, imaging cardiologist from Imperial, and Sam Dawkins, also an interventional cardiologist who's from Oxford. We're here to discuss around transcatheter mitral valve interventions, an area of big interest, and we're hoping to take you through some of the challenges in this field. Perhaps it's worthwhile opening then talking about the specific classification of mitral valve pathology and some of the distinct complexities around anatomy and imaging. Bushra, perhaps you can provide us with some oversight.
Of course. So I think what's key is to understand that unlike the aortic valve, the mitral valve is quite a complex structure. So not only do you have two leaflets to consider, you have the subvalve apparatus made up of the cords, the papillary muscles, and obviously the ventricular wall underlying the structures. So in terms of understanding etiology and mechanism, it's really important to realise that actually mitral regurgitation is a heterogeneous group of patients where you have primary mitral regurgitation and secondary mitral regurgitation. So I'm going to leave the stenotic lesions to one side for the moment. So in the primary mitral regurgitation, the issue is that of the valve itself. So typically it's leaflets and it's leaflet prolapse. With regards to the secondary forms, so function is another word that's used. There we're really describing disease of the left ventricle primarily, although other causes come into the mix like atrial dilatation, but primarily functional mitral regurgitation involves disease of the ventricle, so the leaflets themselves are actually normal. So having understood those two entities, we can then think in a bit more detail about what's going on and what the mechanism of failure is. And in primary mitral regurgitation, as I've already mentioned, it's usually prolapse as the issue. And what that means is that there is excessive leaflet tissue, typically, where there's motion above the annular plane into the left atrium. And more than 2 millimeters, you would describe prolapse. We can think about a subtype, which is very, very relevant in terms of any transcatheter mitral therapies. And that subtype is described as a flail segment. And again, what that describes is where there is loss of support of the free edge of the leaflet. So where the caudal structures are either significantly elongated but typically ruptured, so primary cords are ruptured, and you get a version of the leaflet tip into the left atrium. And if you see that, really you don't even have to put colour on the valve when you see that. What you know is that you're looking at severe mitral regurgitation. So that's the primary entity. So the secondary mitral regurgitation is essentially describing two key features. So the first in mechanism failure is that the annulus dilates, and we know that it's a dynamic annulus made up 2/3 of a muscular tissue with the aortomitral curtain forming part of the anterior leaflet. And as a result, it's dynamic, it contracts, it changes in size quite significantly, up to 35% during the cardiac cycle. So in that setting, what happens is as the left ventricle dilates, the annulus dilates, not surprisingly, and the leaflets get pulled apart so that there is loss of coaptation. The other issue is that you get this geometric change within the ventricle, and you have this balance of forces, closing forces versus these tethering forces. And what happens is you get an imbalance, either a symmetrical imbalance where both leaflets are pulled into the ventricle in a symmetrical way, such that the mitral regurgitation is primarily more of an annular dilatation issue, or you can get one where there's asymmetry. And with this asymmetry, typically it's seen around P2, P3 because of the nature and the anatomy of the valve and the various forces at work on the valve. And the underlying wall of the left ventricle is also abnormal. So typically you see infarction in the inferior posterior walls. The posterior papillary muscle is affected, and as a result, you have this asymmetric tethering force on the posterior leaflet, and you get leaflet restriction. So the key words I've just mentioned there, just to recap, is prolapse, annular dilatation, and restriction. So they're the kind of things we're looking for when we're trying to understand the mechanism of valve failure.
And so I guess you've emphasised the importance of echo imaging, and it's a critical part of our pre-procedural assessment as well as peri-procedural intervention. I guess one of the other things you brought out was secondary MR being quite different to primary MR, and there are some real challenges in terms of assessing those patients. So before we come to some of the procedural interventional aspects that we as interventionists working with you need to look at, are there other imaging modalities we should be thinking about in that patient selection process pre-procedure, in addition to standard transthoracic and transesophageal imaging?
Yeah, I think so. So obviously, just to recap, transthoracic imaging is very good for making the diagnosis. If you want to understand the etiology in detail and the mechanism, then you need better quality imaging, and typically that's transesophageal echo. The next steps really are that looking at the type of procedure that you may be thinking of. So there are other aspects to consider, not just the leaflet disease and the detail of that, but actually the surrounding anatomy. And I think that's where CT has a role, and certainly in aspects in terms of understanding the ventricle, the papillary muscle positioning, and understanding a key area, which is actually the outflow tract, the left ventricular outflow tract, particularly mitral valve replacement procedures, then I think CT really does have an important role there as well.
And Sam, can you describe from the interventionist perspective some of the challenges, both in terms of our learning? I think you'll agree this is an era of innovation which has required a whole new learning in terms of understanding of valve disease and imaging from an interventionist perspective. But in terms of the procedure, what are the critical aspects in order to ensure a safe and effective procedure? How do we work as a team? And it's a very dynamic process, isn't it? Can you sort of give us a picture of that procedural imaging requirement?
Yes, I think the interaction between the interventional cardiologists and the imaging specialists is crucial for these procedures. Interventional cardiologists are used to doing procedures using fluoroscopy with very little other support. We've all done primary PCIs in the middle of the night without very much assistance from anyone else. But coming to the more complex structural procedures such as mitral intervention and also left atrial appendage occlusion, paravalvular leaks, the imaging support that you have is crucial. Interventional imaging, as I'm sure Bushra will agree, is very different from diagnostic imaging. And the ability for the interventional cardiologist to communicate with the imaging cardiologist to be very clear about what they're looking for, and then once the team have got used to working together, it becomes that the one anticipates the other, and it becomes a very satisfying experience to be involved in. But it is different and it is complicated. And I think as interventional cardiologists, the important thing is that we're very clear about what we're asking for. And also, I personally think that people who want to do structural intervention as an interventionalist should have extensive transesophageal echo experience, and I know you and I have both done a lot of it, and I think it really helps with knowing what you're looking at, knowing what you're asking for, and being able to ask for a particular view. I think that's really important. I think also understanding, I think having some experience of doing TOE yourself makes you realise that the challenges of it, and that you, as an interventionist, it's very easy to ask for what you want, but if you've done some of the imaging yourself, you understand that some patients have really tricky imaging and tricky windows, and to understand that makes for a happier team, I think.
Absolutely. I think we both value having expert echocardiologists like Bushra and acquiring the sort of imaging quality required during the procedure, and I guess we'll start to see it become part of a training portfolio, and it's something for our interventional trainees to think about if they're moving in the structural field. Before we move on, just final question then about imaging and how this might advance, because at the moment we're reliant on the invasiveness of transesophageal imaging, and we need it to identify the complexity. Do you see this evolving in terms of intracardiac echocardiography, which might permit us to take a less invasive approach?
Yeah, so I mean, the ideal is to have as little kit as possible to have the patient under conscious sedation and for them to go home the same day, isn't it? That's what we're all aiming for, and that makes it worthwhile pushing these boundaries. The one thing I would say is that while other imaging techniques are available, such as ICE, the limitation really is that of not being able to use 3D in the way that we can use 3D on TOE currently. However, with ICE, the intracardiac echo, increasingly there are techniques being developed, and the 3D probe is here. At the moment, the angle in which you can view the heart is limited, and the type of 3D modalities available are limited, but I think that will come. And I think certainly if we can do this in a less invasive way and have the patient awake, perhaps, then in fact that would be ideal when you think about the complexity of the patients and their comorbidities. So I think there is definitely things to happen in the future. Yeah.
A lot of development there.